Types of emphysema. Emphysema isn't one uniform disease. The damage that happens within the lung's basic functional unit, the acinus, differs between patients. And this location has real clinical significance. There are three main types you need to know. Centriacinar emphysema, also called centrilobular emphysema. Panacinar emphysema, also called panlobular emphysema. Paraseptal emphysema, also called distal acinar emphysema. Before going further, it is important to know what an acinus actually is. Acinus is the functional respiratory unit distal to a terminal bronchiole, consisting of the respiratory bronchioles, alveolar ducts, and alveolar sacs. All three subtypes of emphysema are named based on which part of this acinus is destroyed, which is why understanding the acinus first makes the rest of this topic click. Now, let's discuss the types of emphysema in detail. Centriacinar emphysema, also called centrilobular emphysema. Location of damage. It involves the central proximal part of the acinus, specifically the respiratory bronchioles, while the more distal alveoli remain relatively preserved, at least early on. Distribution in the lung. It predominantly affects the upper lobes of lungs. Most common cause is cigarette smoking. Why upper lobes of lungs specifically? It is thought to relate to regional differences in ventilation and perfusion, and where inhaled smoke particles and inflammatory cells concentrate most. This is the type you'll see overwhelmingly most often in real practice, since it's the smoking-related pattern. If you remember only one type in real clinical detail, this is the one. Because it's the one you'll actually encounter constantly on the wards. Panacinar emphysema, also called panlobular emphysema. Location of damage. The entire acinus is destroyed relatively uniformly. Respiratory bronchioles, alveolar ducts, and alveolar sacs all affected together, not just the central part. Distribution in the lungs. It predominantly affects the lower lobes. This is the opposite pattern from Centriacinar. Most common cause is alpha-1 antitrypsin deficiency. This is the classic association to remember. The lower lobe, Panacinar pattern is a genuinely high-yield clinical trigger. If you see this distribution on imaging, especially in a patient who is young, or a non-smoker, or has a family history of early emphysema or liver disease, you should actively check an alpha-1 antitrypsin level. Alpha-1 antitrypsin deficiency also predisposes to liver cirrhosis, so it's worth mentioning that connection too. The same missing protein causes disease in two completely different organs by two different mechanisms. Paraseptal emphysema, also called distal acinar emphysema. Location of damage. It involves the distal part of the acinus, specifically the alveolar ducts and alveolar sacs nearest the pleura, the outer lining of the lung, and along the septae, fibrous partitions, within the lung. Distribution in the lung. It occurs along the periphery of the lung, just beneath the pleural surface, often most prominent in the upper lobes near the apex. Distinctive feature. This can form larger air-filled sacs called bullae, just under the pleura. Key clinical association. The subpleural bullae can rupture, thus causing a spontaneous pneumothorax. Classic patient profile. Patients will be young, tall, thin individuals, even ones who may not have significant smoking history or other COPD features. This is the type most likely to show up in a completely different clinical context than the other two. There will not be a breathless COPD patient in clinic, but a young, otherwise healthy person presenting acutely to the emergency department with sudden onset chest pain and breathlessness from a spontaneous pneumothorax. Worth flagging this contrast explicitly, since students often assumed emphysema always means an older smoker with chronic breathlessness, and this type breaks that assumption.